PAT-CR or major pathological response or event-free survival, is this enough for making a decisions in perioperative setting, or overall survival is important, because none of the trials have yet stressed on that? Virendra, what do you think? So,
look, OS in an operable setting, OS is whatever setting it is. I think OS is very important indicator. So till now, with immunos and all, we have event-free and PCR, but it is important to have that OS outcome also. If that is significantly better, then obviously it has got a good benefit. Otherwise, only getting PCR,
it's not a...
Yeah.
So,
and if you see what we have been discussing about other subsite, so in esophagus, if you see, again there was a paper which compared cross versus RT, where PCR is better with cross compared to flot, but there is no survival difference. So that is one important thing which we
that in fact make a difference because we started using more and more flot to avoid the post-cross issues.
We must understand that in many of the sites, PCRs or MPRs have not got converted into OS. We know that if a patient gets an MPR, they do better, but overall in the cohort setting, they are not got converted into OS benefit. But saying that, we must also understand both Checkmate 816 and KI 671 OS data, which you are also showing on the slide, have actually shown that there is a good 10 to 12% separation in the curves. The reason why these were labeled as not positive because these were at interim analysis and the P required was much lower. I think in the Checkmate it was 0.008 and here it is 0.02. So if with longer follow-up, the way the separations are going, is good probability that this data will turn out to be having OS advantage.
Definitely.
And just one more thing to add, Prriya, like many of these therapies, which we give, they have a maintenance. Chemotherapy maintenances we usually do not practice that much. But like when you look at the immunotherapy, usually they are followed by some sort of maintenance. I think even with majority of the immunotherapy, when we see, there is usually a curve flattening, which happens. There is always a tail. I think only the time will tell us, but till that time I feel those who achieve basically PAT-CR, maybe they may be the better responder, Because right now we are struggling with the biomarkers also. I think so, as Dr. Govind Babu sir said, maybe the neoadjuvant is the only chance to know, yes, this tumor is responsive to this particular therapy.
Yes, so Dr. Govind sir, which markers do you normally consider testing in early stage lung cancers?
So if you're looking at the driver mutations, EGFR and ALK definitely, and now BRAF as well.
Okay.
So those three things, because they have a bearing on whether you're going to combine immunotherapy with your targeted therapy or not. So that is what we do. But by and large, most of us are doing an NGS. So
and Kshitij, what do you do? Diagnostic, or you prefer the surgeon getting it out? Though we have already crossed that discussion, yet if
yeah, so usually I prefer on the diagnostic samples because we are ready with the reports. So entire plan.
So what are the challenges all four of you face when you ask for molecular testing in early stage lung cancer? Is it the tissue, the adequacy during diagnosis, or is it the cost factor, or is it?
So our intervention radiologists are fantastic at getting tissue now. So that is one of the least problems. And cost-wise, there are a lot of companies which are giving coupons for the patient. So I think that is also fine. And in our hospital, we are doing NGS for most of them. And if again we feel that they cannot afford, we have a research part of that. So that goes into that.
Okay.
We are talking, if the PD-L1 is going to be positive, we are going to use immunotherapy. So it's better that we get the mutation testing done in these patients on the diagnostic sample, because if they are mutation positive, these were not the patients which were included in the study. So data is not applicable for those patients. If it turns out to be EGF from mutation positive, I'm going to ask Virendra, you operate it first, I'll give adjuvant chemo and then I'll put him on osimertinib material. I'm not going to give neoadjuvant immunotherapy in that patient.
Yeah, so stressing de-stressing that for the students is what I'm a surgeon. I operate.
So then just restrict testing to EGFR and PD-L1 in diagnostic specimen. If you know you're going to end up doing surgery, likely end up doing surgery. So do you restrict to EGFR and PD-L1? Do you do EGFR, ALK and PD-L1, or do you want the complete panel and PD-L1 to decide whether you're going to give neoadjuvant chemo, immuno or not?
My personal bias always, I have a lot of biases, is a complete NGS for me. It is not just for deciding on your treatment, but for understanding so many things which we don't know.
Right, so suppose you do, if the patient is planned for surgical resection,
Yeah.
you end up getting a BRAF positive. Are you going to deny immuno-chemo combination to that patient because you picked up a BRAF?
In fact, for BRAF, they have shown that there is no adverse events when you combine the targeted therapy with immunotherapy. It is for ALK and EGFR, but not for BRAF.
Correct. So if testing for all of the others does
Yeah.
not influence the decision to give neoadjuvant chemo immuno, why test them? Because the resected specimen is going to give you much larger tissue and perhaps more accurate testing results than a small diagnostic specimen. So if the only things which you need to know regarding combining immuno to chemo is EGFR and ALK, then just test EGFR and ALK and not test the others.
Yeah, you can argue both ways. So after surgery, if you're going to get a larger tissue, even there you're going to take only a core for your analysis. It is not that you're going to homogenize the whole thing and take. So that will not make any difference.
Okay, for simplicity, this patient underwent surgery. Virendra took it over.
Anup is worried if the patient goes into PATSIA, there will be no tissue to.
Very valid point, actually. It's a valid argument to say.
We have had that in many head and neck cancer patients.
And this thing, most of the trial are actually what sir is selling is ALK and EGFR they are testing. Even I have actually asked to the central lab in US whether they are performing NGS without our knowledge on the samples what we have sent. So they have properly told that no, they are not doing NGS.
They're not supposed to do it.
Or if they are doing, they are not telling us. So according to what Govind Babu sir is telling is right, because in future we are going to have more and more trials which are going to test for other parameters also, other molecular markers.
Yeah.
Some will favor, like KRAS will favor immunotherapy. EGFR ALK is not favoring immunotherapy. So I think this is for research purpose, yes. But for practical, what sir is telling is EGFR ALK is required.
Very soon we may have that, like the NSCLC data which came for KRAS, KEAP1 and STK11. We may get that data in neoadjuvant setting also. That if you have all these three mutations, that immunotherapy doesn't work. So at present, what is suggested is correct. We have limited information. We have information that in the trial EGFR and ALK was done, and this. But if you're an academic institute or an institute which wants to collect data, there is no harm in getting a complete done also.
So something which is called luxury and something which is called necessity. So necessity is EGFR ALK, luxury is if you have the chance to do everything. So Virendra operated. Let's end the discussion. Post-operative, he was given 4 cycles of chemotherapy. Once he came back for follow-up to the medical oncologist, it confirmed EGFR exon 19 deletion and PD-L1 25%. Kshitij, what do you do next?
So osimertinib.
काम खत्म कर So you have any adjuvant, anything else you want to do combination, you want to do only adjuvant TKI? Ashay, what would you prefer? You want a combination of TKI and chemo?
So basically, he's already received 4 cycles of chemotherapy. So anyway, whenever there are 2 situations, patient is fit, you will give 4 cycles of chemotherapy, platinum based, and followed by the osimertinib maintenance. Patient is unfit, means directly we go for the osimertinib maintenance.
Okay, so we have gone to the end of the discussion and we have Kshitij has decided osimertinib, so we go for osimertinib. So confirming the Aurora trial, which showed that there was a benefit of giving osimertinib, and I think that has been proven to be without doubt in most of the lectures we've had since morning. So it showed significantly improved DFS in primary as well as in overall population, and patient has a absolute benefit of 5 years of 12%. That brings to the end of the panel. In view of time, we all know that we have done this, and patient goes ahead with only post-operative osimertinib after the chemotherapy. Thank you.
Would you consider if the patient is affordable, stopping the osimertinib after 3 years or continuing the osimertinib?
Well, that's a good question. So, I don't know, we had a ISLC webinar on ASCO highlights, and so I was assigned discussing the ADAURA trial, and one of the questions were, can you define which patients don't require 3 years, and defining patients in whom you should not stop at 3 years. We don't know the answer, whether it is MRD monitoring by ctDNA, whether it is an inherent other marker. For example, you are testing EGFR, but you may end up doing an NGS and you may pick up a concomitant TP53 or something else which tells that this patient is not going to respond as well to TKI monotherapy as a pure EGFR mutation. And so you would be tempted in such patients to continue therapy and not stop therapy. In real world settings, the data will stop, the evidence will stop at the point at which data was collected. And beyond that, you have to use your clinical judgment. And that applies to whether patients are able to afford osimertinib or not. And you have a patient who has undergone surgical resection, you have an EGFR positive, the patient cannot afford osimertinib. Will you not give another TKI? I would, even though there is no evidence.
So we recently had a conference on MRD in solid tumors. So this is what one of the arguments, and this is happening in the T790M mutant patients. They're actually following it up, like the analogy is the BCR-able CML. So these are things that are going to definitely come up.
Sir, just one question. What is the reservoir of the residual tumor of early lung cancer? It is like second de novo at relapse, or since we are giving osimertinib for 3 years, what is the actual reservoir? What we are trying to kill? The micromates, whether they are lung or blood.
Everywhere. So you have done perhaps neoadjuvant therapy. You have done surgical resection. You have achieved probably an R0 resection, nodes are okay, maybe they are N0. All what you are doing with adjuvant therapy is trying to take care of micrometastatic disease, a few cells which may have escaped in the circulation in the perioperative period, and so basically wipe out the disease. The important argument is osimertinib or any of these targeted therapies are cytostatic. They are not cytotoxic, and so despite the ADAURA trial data, when we formulated the stage 3 NSCLC guideline updated ASCO, we made it clear that patients should receive adjuvant platinum-based chemotherapy wherever eligible and then go on to adjuvant osimertinib and not just omit chemotherapy.
Yeah, I think that's a very important point that's been stressed for all these adjuvant TKIs.
I thank you all the panelists for a wonderful discussion.